Hey everyone, and welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Mariam, and joining me today is Ghedaa, who's going to walk us through one of our smallest but most powerful glands, the pituitary.
Hello, Mariam. I'm very excited for today's episode. By the way, did you know that the pituitary gland is also called the master gland?
Oh, really? I didn't know that.
And for good reason, too. Even though it's the size of a pea, it controls most of the other endocrine glands in the body.
Alright, I don't know about you guys, but that sounds very interesting to me. But before we dive in, let's give our listeners a quick roadmap of what we're going to cover in today's episode.
Absolutely. By the end of this episode, you'll have a solid grasp on the basic anatomy and physiology of the pituitary gland. And we'll explore a variety of pituitary disorders, both hyper and hypofunctions.
Exactly. And when we say pituitary disorders, we're talking about the whole spectrum, from pituitary tumors like prolactinomas and corticotroph adenomas to congenital abnormalities, inflammatory conditions, and even infarctions and trauma-induced damage.
It sounds like a lot, but don't worry. We'll break it down piece by piece so you'll absolutely master everything that has to do with the pituitary gland by the end of this.
Yeah, so get comfy, grab your coffee, or if you're driving, grab your steering wheel, turn on the signal for once, and let's jump in. Alright, Ghedaa, let's start simple. Where exactly is the pituitary gland?
It's located right at the base of the brain in a little pocket within the sphenoid bone called the sella turcica.
So it's kind of nested in the center of the skull, right beneath the brain. And size-wise, is it tiny, like what, a few millimeters?
Yeah, actually, it's pretty small. It stays within 13 millimeters and it weighs around 600 milligrams. But keep in mind, it sits next to some major structures, like the optic chiasm, the cranial nerves 3, 4, 5, and 6.
Okay, so that's why the pituitary tumors can mess with vision or even cause cranial nerve palsies.
Exactly. Because of how tightly packed that area is, a lesion there can definitely push on those sensitive structures.
Alright, let's talk about the pituitary itself. If I remember correctly, it has two main parts, the anterior and the posterior pituitary.
Oh yeah, the anterior lobe, also called the adenohypophysis, makes up about 80% of the gland. The posterior lobe, on the other hand, or the neurohypophysis, stores and releases two hormones that are actually made in the hypothalamus.
So the posterior pituitary releases two hormones, the ADH and oxytocin, which is made by the hypothalamus.
Exactly.
Okay, so let's focus on the anterior pituitary for now. It develops embryologically from Radke's pouch, which is the oral cavity, right?
Yep, and histologically, the different cells in the anterior pituitary have different colors depending on the hormone they produce. First off, we have the eosinophils, which look reddish or pink, and those are the cells that make growth hormone and prolactin. Then there are the basophils, which have a bluish tint to them. They make all the other hormones, like thyroid stimulating hormone, TSH, adrenocorticotrophic hormone, ACTH, luteinizing hormone, LH, and follicle stimulating hormone, FSH.
Okay, so the GH and prolactin cells are acetophils, while all the other ones are basophils. And is that how we usually tell them apart?
They don't really use the color classification anymore. What's more important is the immunohistochemistry stain. And that's exactly how we can tell which type of cell we're looking at.
So the immunohistochemistry is when we're looking for specific antigens on each cell type for recognition.
Exactly, and that way we can classify the anterior pituitary cells into 6 functional types. We have somatotrophs for growth hormone. Just remember, when we say somato, we're talking about growth hormone. Then we have lactotrophs for prolactin. Think of lactation for that one. And then there are mammosomatotrophs, which are essentially a combination of somatotrophs and lactotrophs that both make growth hormone and prolactin.
Okay, so bear with me. So far, we have the growth hormone from the somatotrophs, the prolactin from the lactotrophs, and both the prolactin and the growth hormone from the mammosomatotrophs.
You got it. And after that, we have corticotrophs for ACTH. Just think of adrenocorticotrophic hormone. And then thyrotrophs for TSH. And the name for this one is pretty obvious. And then after that, we have gonadotrophs for FSH and LH.
All right, so ACTH is from the corticotrophs, the TSH is from the other T, which is thyrotroph, and finally, the gonadotrophs gives off both the LH and the FSH.
Perfect. You nailed it.
All right, now that we've covered the basics, let's get into the clinical side of things, starting with a general overview of pituitary adenoma, which is my personal favorite.
So generally, when we say adenoma, we're talking about a benign tumor that arises from the anterior pituitary. It's actually the most common cause of hyperfunction of the pituitary.
Got it. So even though it's benign, it can still cause issues.
Exactly. It can either produce excess hormones, which we call a functioning adenoma, or it doesn't secrete anything, which we call a non-functioning adenoma. However, both produce a mass effect.
Okay, but how exactly?
So, as long as they get big enough and compress nearby structures, they can cause a mass effect.
Oh, okay. But how do we classify them?
So, we mainly classify them based off of their function and the type of hormone they produce. Basically, we call it a functioning adenoma if it produces excess hormones that can cause clinical symptoms. However, if it makes excess hormones but they do not have clinical symptoms, we call it a silent adenoma.
Okay, just to get this straight. Functional causes symptoms, while silent does not. However, both of them end up producing excess hormones. So, Ghedaa, is a silent adenoma the same as a non functioning adenoma?
Not exactly. A null cell or a non functional adenoma does not make any hormones at all. But a silent adenoma does. They just don't cause symptoms.
Alright, and based on the type of the cell the tumor comes from, we get different hormonal profiles.
Yeah, so for example, as we said, a lactotroph tumor makes prolactin, and a somatotroph tumor makes growth hormone, a corticotroph one produces ACTH, and so on and so forth.
Okay, since they're different types, are they also different sizes?
That's another way to classify pituitary adenomas, either micro or macro. Microadenomas being less than 1 centimeters and macroadenomas being 1 centimeter or larger.
Ooh, okay, so this distinction is important because macroadenomas are the ones that are likely to press on nearby structures and cause a mass effect.
Exactly. So they may cause symptoms of elevated intracranial pressure like headache, nausea, vomiting, or another classical presentation is bitemporal hemianopsia if it pushes on the optic chiasm.
Okay, I have a question. What if this tumor grows beyond the sella and starts invading other nearby tissue, like for example the dura, the bone, or maybe even the brain itself?
Well, in that case, we call it an invasive adenoma.
Okay, just to make sure I'm following. Pituitary adenomas can either cause problems by secreting hormones or by physically growing and pressing on things, or in both ways, depending on their size.
Exactly.
Is there any specific cause for these adenomas?
So most of them are sporadic, but they can be also seen in genetic conditions like MEN1 or multiple endocrine neoplasia type 1.
Alright, so are there any mixture of letters we're supposed to remember, or in other words, mutations?
The thing is, there are many mutations that may be involved in pituitary tumors. But an important one to remember is a mutation in the HRAS oncogene. The HRAS mutation could indicate that this tumor has a high chance of becoming a malignant pituitary carcinoma.
Alright, I think that gives us a very solid overview. Now let's dive into our first case.
Our first patient today is a 28-year-old woman who came into the clinic with amenorrhea and milky nipple discharge for the past 6 months. She also mentioned decreased libido and trouble getting pregnant. On further questioning, she said she's been getting dull headaches recently. Her labs showed elevated prolactin levels, and her MRI revealed a 6 mm cellular lesion.
Okay, I think I've got this. So we've got a patient with amenorrhea, galactorrhea, infertility, and a pituitary lesion. So if I'm right, this must be a prolactinoma?
Yeah, this is a classic presentation. Prolactinomas are pituitary adenomas originating from the lactotroph cells. And they are actually the most common type of functioning pituitary adenoma.
And to add on that, they tend to be detected earlier in women than men, especially during their reproductive years.
Exactly. That's because when women experience amenorrhea, they get alarmed and will likely visit the doctor. But in men, the symptoms are more subtle, like decreased libido or infertility. So their tumors are often detected later and tend to be larger by the time they're caught.
So all these effects we see are because of hyperprolactinemia.
Yep.
This sounds kind of messy, but can a pituitary tumor cause the same presentation of hyperprolactinemia without producing prolactin itself?
Yes, actually. Any mass in the supracellular region can cause something called the stalk effect. But before we explain that, we need to remember the effect of dopamine on prolactin.
Oh my god, yeah, I know this one. Dopamine is being released from the hypothalamus, and then it blocks the release of prolactin itself.
Yes, and in order for it to reach the anterior pituitary from the hypothalamus, dopamine needs to pass through the pituitary stalk.
Oh, so if we compress the stalk, we block dopamine from inhibiting prolactin.
Exactly, and that's what we call the stalk effect. It causes mild hyperprolactinemia, even if the mass itself isn't a prolactinoma.
Okay, but why does excess prolactin cause all of these reproductive symptoms anyway?
Good question. That's because prolactin inhibits GnRH, which leads to you not being able to make LH and FSH, and that's what causes amenorrhea, infertility, and low libido.
Okay, so prolactin inhibits GnRH. Got it. Now we've been talking about this prolactin for so long. Shall we put a face to the name and learn how it looks under a microscope?
Microscopically, most prolactinomas are chromophobic and sparsely granulated.
So basically, they don't really have a color and their granules are fine and tiny.
Exactly, and they're also known for having amyloid deposits and microcalcifications.
Okay, so list with me. They're chromophobic, sponsor granulated cells with amyloid deposits and microcalcifications.
Exactly.
Okay, how do we go about diagnosing a prolactinoma?
So when you get a patient with symptoms suggesting hyperprolactinemia, you need to start by measuring serum prolactin levels, which you should see elevated.
And remember, guys, the normal levels are less than 18 in males and less than 24 in females.
And adding to that, in microadenomas, prolactin levels are high, but usually they do not go above 200 micrograms per liter. If it's above 200, you should start thinking about macroadenomas.
We also need to rule out other potential causes of elevated prolactin before reaching a diagnosis, right?
Yes, definitely, especially if the elevated prolactin levels is still below 200. You're gonna need to make sure that you're not dealing with pregnancy, hypothyroidism, chronic kidney disease, chest wall trauma like shingles, or any dopamine inhibiting drugs like antipsychotics. It could also be the stalk effect we talked about earlier. All these things can elevate prolactin, but will not go above 200.
To follow up, if prolactin is high and above 200, we're likely dealing with a macroprolactinoma. But if it's high and still below 200, it could be a microprolactinoma or any other cause of elevated prolactin like the stalk effect.
Yep,
And then the next step after prolactin levels is imaging, right?
exactly. An MRI of the pituitary with and without contrast. This helps us locate the lesion and measure its size.
Okay, so let's say we found a prolactinoma. What is the go-to treatment?
The first line treatment for prolactinomas is dopamine agonists like carbogyline or bromocriptine. This should make sense since we know that dopamine blocks prolactin production. And while both can be used, carbogyline is generally more preferred. What is so nice about this is that not only it reduces prolactin levels, but it also shrinks the tumor in most patients.
That's great. Does that mean that they will not need surgery?
Well, usually, most patients should be good to go with these meds alone. But unfortunately, some patients don't respond to meds or can't tolerate them. In that case, they will need surgery.
And is radiation ever a part of the treatment plan?
It's rarely used.
So what you're saying is that they're usually fully cured just by carbogyline.
Yes. And fun fact, if a microadenoma disappears with carbogyline treatment, we can just stop the drug and keep the patient under close monitoring to make sure that if the tumor goes back, we can catch it early on.
Okay, that sounds perfect. Shall we bless the listeners with a practice question?
Let's start. We have a case of a 28-year-old woman presenting with amenorrhea, galactorrhea, and infertility. Labs show elevated prolactin, and an MRI reveals a 6 millimeter pituitary lesion. What explains her infertility? The answer is either suppression of GnRH by prolactin or compression of gonadotrophs by the tumor.
Oh yeah, we can also have compression of the nearby gonadotrophs. And because both of these ultimately reduced LH and FSH, the patient experienced anovulation and infertility. Okay, Ghedaa, let's point out some key features of prolactinoma that distinguishes it from other pituitary adenomas for our lovely listeners.
Sure. Prolactinomas are the most common functional pituitary adenoma. Symptoms are often reproductive, like amenorrhea, galactorrhea, and infertility. It's usually managed medically with dopamine agonists, mostly carbogyline, and histologically, you should see chromophobic, sparsely granulated cells with amyloid deposits and microcalcifications.
Okay, I think we're ready to move on to our next case, no?
We'll cover a case of a 50-year-old woman who came in with joint pain, coarse facial features, and this weird thing she noticed. Apparently, her shoes don't fit her anymore, and that she has had to get her rings resized. She also mentioned that she sweats more than usual and she just feels heavy. Labs showed elevated IGF-1, and when we did the glucose suppression test, her GH stayed stubbornly high. MRI showed an 8 millimeter region in the pituitary.
Alright, let me guess. Big hands, big feet, facial changes, and a GH that's stubborn after glucose. This has to be acromegaly.
Yup, another very classic presentation. Acromegaly, in most cases, is a growth hormone-secreting pituitary adenoma, which we can call a somatotroph adenoma.
If this had happened to her as a kid before her growth plate had fused, she wouldn't have just big hands, right?
Yup. In that case, she would have had gigantism.
Like Andre the Giant. This guy was practically a walking case study.
Exactly. And children with excess growth hormone just keep getting taller because of the epiphyseal plates that haven't fused yet, so they get gigantism. Adults with excess growth hormone, though, they can't grow longer bones, So their bones become thicker instead, and they get acromegaly.
Does the growth hormone do all these changes by itself, or is there anything else involved?
The main culprit here is usually IGF-1, aka insulin-like growth factor 1. Basically, the tumor makes growth hormone, which tells the liver to make IGF-1, and IGF-1 is what drives the tissue growth and the bone thickening and the organ enlargement, all of it.
Ooh, so it's not the direct effect of GH that causes the problem, but rather it's the IGF-1.
You got it.
I'm curious, what do these GH secreting cells actually look like under the microscope?
Most of the tumor cells are densely granulated, acidophilic cells that stain strongly for GH.
Okay, so these somatotrophs are pink and have dense granules. That's like the complete opposite of chromophobic cells with fine granules that we see in prolactinomas.
Yep.
Okay, now that we're trying to diagnose these tumors, growth hormone levels are a bit unpredictable, right?
Oh, absolutely. The thing is, growth hormone naturally fluctuates throughout the day, so you can't rely on a random level. Instead, we check IGF-1 because it's stable and stays elevated in acromegaly, no matter how much growth hormone fluctuates.
Okay, so the go-to screening test for acromegaly is IGF-1. What if it's high?
Well, in that case, we do the glucose suppression test. Basically, you give the patient 75 grams of glucose, and normally that should make the GH drop below 1 nanogram per milliliter. But in acromegaly, GH refuses to go down and its level stays high.
Alright, so GH doesn't drop after the glucose suppression test and stays elevated. What's the next step?
After confirming the diagnosis biochemically, we move on to imaging. Basically, we do an MRI with contrast to localize the lesion. Most of the time, it's a macroadenoma, but if you remember, our patient had an 8 millimeter lesion on her MRI. So her microadenoma still caused a full-blown acromegaly.
Okay, now what's our management plan? What do we do first, Ghedaa?
First line is a transsphenoidal surgery. And even if it's a macroadenoma that's difficult to reach, we still try to get as much of it out as we can. If it's not completely resectable, or if symptoms persist after surgery, we bring in the meds.
So we would need drugs that block the growth hormone in some way, no?
Yes, this is where octreotide, a somatostatin analog, comes into play.
Somatostatin blocks the release of growth hormone, right?
Yes, exactly. And then you have pegvisomant, which is an antagonist at the GH receptor. Finally, you can use a dopamine agonist like carbidoline, but this one has a weak effect.
If you treat these acromegaly patients well, do you get rid of all their health issues as well?
Yes, luckily, with proper treatment, if you normalize IGF-1 and GH, your patient can go back to normal life expectancy. But if left untreated, acromegaly significantly increases the risk of cardiovascular diseases like heart failure.
Alright, listeners, it's time for yet another quiz.
A 50-year-old woman presents with fatigue, coarse facial features, and enlarged hands. Her IGF-1 is elevated and her GH level remains high after a glucose test. MRI reveals a pituitary lesion. What is the most likely histological finding seen? The answer is acidophilic cells, with dense granules that stain strongly for GH.
Alright, so what's next on the agenda, Ghedaa?
For the next case, we have a 41-year-old man who presents with a new onset diabetes, easy bruising, proximal weakness, and some wide purple stretch marks over his abdomen. He also mentioned gaining weight mostly around his trunk, and on examination, you notice a classic moon face and a bit of a buffalo hump. Labs show 3 different values: elevated midnight salivary cortisol, a high 24-hour urinary cortisol, and elevated ACTH. Surprisingly, his pituitary MRI was normal.
Okay, so I'm guessing this guy has Cushing?
Yep, most likely.
So now we need to figure out where all this extra cortisol is coming from.
Exactly. So let's break it down. When we say Cushing syndrome, we're essentially just saying there's too much cortisol. But that can be due to one of 4 possible sources, either from the adrenals themselves, or from a tumor in the pituitary, or from a tumor somewhere else, or even from steroid medications. When it's coming specifically from a pituitary tumor producing ACTH, that's when we call it Cushing disease.
Ooh, okay. So Cushing syndrome is the umbrella term for hypercortisolemia in general. And Cushing disease is a specific subset of that syndrome where a pituitary tumor makes too much ACTH.
Yep. So in Cushing disease, you've got a corticotroph pituitary adenoma shooting out ACTH. In most cases, it's a microadenoma. This ACTH goes straight to the adrenal glands and keeps the cortisol coming.
And I'm assuming that cortisol makes a huge mess when it's elevated.
Yeah, definitely. It starts messing with glucose and fat distribution and protein breakdown.
Okay, Ghedaa, let's slow down things for a second. If a Cushing's patient walks into your clinic, what kind of features are you really expecting?
The thing is, Cushing's is one of the syndromes with features that stand out when you look at a patient. They usually have a rounded, plethoric, moon-shaped face, and you can see that little buffalo hump over their upper back.
And they usually carry most of their weight around the trunk, right?
Exactly. They usually have central or truncal obesity. Basically, most of the fat is around their trunk, but their arms and legs are skinny.
Oh, and I think they have these stretch marks, right?
Well, not exactly. They have broad purple striae, especially across the abdomen. And these striae are not just stretch marks, they are wider and purple colored.
So, striae and not stretch marks. Got it. And they also bruise pretty easily, right?
Yes, absolutely. Even small bumps might leave marks. They also have proximal muscle weakness, especially in the thighs and shoulders. So if you ask them to stand up from the chair without using the support of their arms, they might experience some difficulty.
Okay, so they're struggling with movement, they're bruising, they've got central fat and striae. What else?
They might also be dealing with new or worsening diabetes, high blood pressure, or even osteoporosis. Some patients may even experience psychiatric problems like depression, irritability, or even cognitive fog.
So basically, what you're saying is that if someone shows up with features of metabolic syndrome, mood swings, muscle weakness, and skin findings, we should think of Cushing's.
Exactly.
And our patient in this case has a new onset of diabetes, high blood pressure, proximal weakness, and striae. So he's definitely checking off the four things.
Yep. And look at the clue in his gender. When you see a man with ACTH dependent Cushing's, it's more likely to be from an ectopic source, like lung cancer. So that's something to keep in mind as well.
So, what histological appearance do we see in the pituitary of patients with Cushing's disease?
These patients have pituitary adenomas called corticotroph adenomas. These ACTH producing tumor cells you see are typically basophilic and densely granulated. And what's unique is that they're PAS positive. That's because the precursor of ACTH, which is called pro-opiomelanocortin, POMC, lights up with the PAS stain.
What about their size?
Most of the time, these tumors are small microadenomas.
Okay, warning, a mouthful is coming. So, if you have a patient with signs of cortisol overload, and then you see past positive pituitary microadenoma with basophilic and densely granulated cells, you're probably looking at a corticotroph tumor.
Yes, and keep in mind that the growth hormone producing adenomas are also densely granulated, but those ones are acidophilic, while ACTH cells are basophilic.
Okay, so let's say someone comes in, like our patient, with symptoms of elevated cortisol. How do we really approach the patient, or what is the diagnostic criteria?
The very first thing you must do is screening for cortisol excess. For that, we have 3 tests. The key is having at least 2 out of these 3 tests positive to confirm hypercortisolemia. You can do either the midnight salivary cortisol, or the 24-hour urinary free cortisol, or the low dose dexamethasone suppression test.
So those screening tests tells us if we have high cortisol, but now how do we localize the issue itself?
The next step to know where the problem is exactly is checking ACTH, because that can eliminate 2 out of 4 of our main differentials of elevated cortisol. If ACTH is low, then the initial problem is high cortisol either from the adrenal or from exogenous steroids. On the other hand, if ACTH is high, then this high ACTH is the initial problem that's causing the high cortisol, and that ACTH can be either from the pituitary or ectopic.
Okay, so let's say the patient does indeed have elevated ACTH levels. How can we really tell if it's coming from the pituitary itself? Do you think we need an MRI?
Usually, we wouldn't do an MRI right away because, if you remember, non-functional pituitary adenomas are pretty common and in many cases, they never cause any issues. So, if you do an MRI for a patient with high ACTH, see an adenoma and decide that this is what's causing the problem, you might completely forget to look for a possible lung cancer, producing ectopic ACTH, and that would be a disaster.
Okay, then. What's the best way to locate the source of ACTH?
We usually go for inferior petrosal sinus sampling, or IPSS. It measures ACTH in both the central veins around the pituitary and in the peripheral veins, and compares the level of ACTH in both locations.
So, if ACTH is higher centrally, beside the pituitary, then that's the source of ACTH. But if it's the same centrally and peripherally, then the ACTH is probably ectopic.
Exactly.
Okay, so how do you treat this pituitary adenoma causing this Cushing's disease?
The first line treatment is transsphenoidal surgery to remove the tumor.
And how do you know if it worked?
So, if the patient's cortisol drops really low post op, that's actually a sign of success. It means that the ACTH source is gone.
But wait, hold up. Isn't it bad for their cortisol to drop so low? Do we need to give them steroids?
Yes, we need to replace their cortisol temporarily using medication until the normal pituitary cells recover and the adrenal axis resets and goes back to normal.
But what if surgery doesn't work?
Well, if surgery doesn't work, we may have to try medical therapy, like ketoconazole, which inhibits cortisol production, pasireotide, which is a somatostatin analog that is used to reduce ACTH, mifepristone, which blocks cortisol receptors, or we might even go for radiation therapy. Sometimes, though, unfortunately, that all doesn't work and patients still have high cortisol and are experiencing Cushing symptoms.
Not to assume the worst or anything, but what would be the last resort in such a case?
If we've run out of options and the patient still has high cortisol, we can just go and remove the source of that cortisol.
Okay, and that would be an adrenalectomy, right?
Yeah, we remove the adrenals.
Let me guess, that would definitely cause some sort of problem, right?
Yeah, these patients may experience Nelson's syndrome after the adrenalectomy. Basically, if you remove both adrenal glands, there is no cortisol left to put the brakes on the pituitary.
But didn't we remove their tumor by surgery?
Sometimes, parts of the tumor are difficult to reach by surgery, so they can still remain. Now, if we remove the adrenals, we remove any negative feedback on ACTH release from this tumor remnant and from the normal parts of the pituitary gland itself. So ACTH can suddenly blow up and the tumor grows and becomes aggressive, raising ACTH through the roof and even causing skin hyperpigmentation.
Okay, you lost me there. Why hyperpigmentation?
Because if you remember, one of the molecules that go into making ACTH also stimulates melanin production.
Oh, right. So basically, Nelson's syndrome is when we fix Cushing's symptoms, but not the ACTH problem itself.
Yeah, pretty much.
Okay, time to put on our little lab coats and answer this practice question.
A 41-year-old man presents with moon faces, abdominal striae, hypertension, and high ACTH. IPSS shows higher ACTH in central veins than in peripheral. What types of cells do you see in this pituitary? The answer is PAS-positive basophilic tumor cells with dense granules, a key feature of corticotroph adenomas.
Our next type of pituitary adenoma is the TSH secreting one. This one is quite rare, but let's talk about it for a little bit.
That's correct. They're the least common of all functioning pituitary tumors. Despite this, they're important, as they can present with signs and symptoms of hyperthyroidism and may be mistaken for Graves' disease.
Wait a second. Wouldn't that be considered as secondary hyperthyroidism?
Exactly. So all thyroid function tests should be elevated.
So we're talking about high T3, high T4, and high TSH.
Absolutely. And because of the elevated TSH, these patients often have a goiter. Because, as we know, TSH stimulates the thyroid gland's growth.
You're right. But I have a question. Can they also have symptoms of ciliary mass effect?
Precisely. They may have headaches or visual field defects.
Got you. Is there any particular test that helps confirm the diagnosis?
Other than TFTs that we talked about, these patients also have elevated alpha subunit levels. This alpha subunit is produced in excess by these TSH tumors. And then, after you confirm your suspicions with the labs, you follow up with a pituitary MRI.
And how about treatment options?
Our first line treatment is surgery.
And let me guess, we're talking about transsphenoidal surgery, right?
Yes. Then, if surgery doesn't work, we can use drugs. You know what? Interestingly, this type of tumor also responds to somatostatin analogs, like the growth hormone adenoma did.
Okay, so you're basically saying that to treat TSH adenoma, we usually go for surgery as a first choice.
Exactly. So remember, it's a rare tumor that presents as hyperthyroidism with high TSH, and you need to look for a mass, check for alpha subunit, and treat with surgery first. Then, if needed, give somatostatin analogs.
Alright, so we've talked about the pituitary and how it goes into overdrive, or in medical terms, hyperfunction. Now let's look at what happens when it starts to slow or shut down instead.
Then, it becomes pituitary hypofunction, which means the pituitary isn't making enough hormones, and that can affect one axis, or all of them.
And unlike hyperfunction, where symptoms are pretty dramatic, hypopituitarism can sneak up slowly through fatigue, infertility, and even growth failure in kids.
Exactly.
So, shifting gears now, let's take a look at our first case of hypopituitarism. Not the most dramatic condition, but hey, it has its moments.
Our next case is a 55-year-old man who's been feeling increasingly fatigued over the last year. He has also noticed decreased libido, and his wife points out that he's become more forgetful and withdrawn. He recently saw an ophthalmologist for trouble seeing things beside him, and a visual field test showed bitemporal hemianopsia. Hormonal labs showed low LH, FSH, and testosterone, and an MRI revealed a 3 cm cellular mass compressing the optic chiasm.
Okay, so it looks like we've got low LH, FSH, and testosterone in our hand. Did I miss something else?
Yes, the patient has the classic visual field loss that presents with pituitary tumors.
So you're saying that there's a pituitary tumor with decreased hormone production. How is that possible?
If you have a tumor growing in the pituitary gland, it could compress the normal nearby cells, and so they won't do their job as they should. Remember, we said that could also happen in prolactinoma.
Wait a second. Could this be a non-functioning adenoma?
That's very likely, as none of the pituitary hormones are elevated to clinically significant levels. It's probably a non-functioning adenoma. And since we have mass effect symptoms, it's probably a macroadenoma, not micro.
So where I'm getting at is that non-functioning pituitary adenomas don't produce clinically significant levels of hormones. And because of that, they often go unnoticed until they grow large enough to cause mass effect. So they usually get to the point of becoming macroadenomas.
Exactly.
And when we say clinically significant levels, does that mean that the hormones could still be present inside the cells and just not detectable in the bloodstream?
Yeah. Basically, these adenomas may be clinically silent adenomas, as we said at the very beginning. By silent, we mean they may produce hormones at the tissue level, but they don't trigger symptoms. However, if they produce no hormones at all, we call them null cell adenomas, or non-functioning adenomas.
Since we've kicked off the hypopituitarism discussion, let's dig deeper into different causes, shall we?
We'll do that by delving into our next case. We have a case of a 35-year-old woman who recently gave birth but had a complicated delivery with heavy postpartum bleeding. A few weeks later, she starts feeling exhausted, complains of cold intolerance, and tells her doctor that she hasn't been able to breastfeed at all. Her periods haven't returned, her blood pressure is low, and she's noticed hair thinning. Lab tests show low cortisol, low TSH, low LH and FSH, and low prolactin.
Wow, now that's a whole lot of lows right there. Definitely pointing us towards our little drama queen, the hypopituitarism.
Exactly. And since she has a history of postpartum bleeding, this is a classic presentation of Sheehan syndrome. This is actually one of the most well-known causes of acquired hypopituitarism in women.
Now, let's dive into hypopituitarism itself, starting with what it actually means.
Hypopituitarism is when the pituitary isn't producing enough hormones, specifically the anterior pituitary. It can either be partial or complete, and you don't usually see symptoms until about 75% of the gland is destroyed.
That's kind of crazy. But in addition to that, we have quite a lot of differentials to consider when we're assessing hypopituitarism, right?
Precisely. It may be due to a non-functioning pituitary adenoma, which slowly compresses and damages the normal hormone-producing tissue.
Wait a second, that sounds a lot like one of our previous cases.
Yep. Another major cause is ischemia of the pituitary gland, like what we saw in our patient with Sheehan syndrome. Basically, in pregnancy, the anterior pituitary grows a lot bigger to accommodate the new hormonal state of the body. But the problem is that the blood supply does not grow with it, so it becomes susceptible to infarction if blood supply decreases.
And that's why postpartum hemorrhage can cause infarction and ischemia of the pituitary.
Exactly.
You're boosting my ego way too high, Ghedaa. But I have a question. Does it only affect the anterior pituitary?
Don't worry, I'll make sure to bring it down a notch. Yes, usually only anterior, because the posterior pituitary gets direct arterial blood, so it's protected against infarctions.
Are there perhaps any other causes of hypopituitarism?
Yes, you can also see hypopituitarism because of iatrogenic damage, like after pituitary surgery or radiation therapy. Or sometimes, hypopituitarism may be due to some sort of infiltrative disease, like sarcoidosis, tuberculosis, or hemochromatosis.
What about, let's say, head trauma? Can that lead to hypopituitarism too?
Head trauma, shock, or increased intracranial pressure can all damage the pituitary gland.
Okay, enough of that. And let's shift to symptoms now. What do you see when specific hormones go down in hypopituitarism?
Let's go over them one by one. What do you expect with GH deficiency in kids?
Oh, okay, test time it is. Let's do it. Gut failure, then pituitary dwarfism.
Nice. Now, what about gonadotropin LH and FSH deficiency?
Easy. Amenorrhea, infertility, and low libido.
TSH deficiency?
Okay, so that's hypothyroidism symptoms. So I'm thinking fatigue, weight gain, cold intolerance too.
Wow. Now, ACTH deficiency.
Okay, this is getting low-key stressful, but I think low cortisol, hypertension, and weakness.
See? I told you I'll be able to bring your ego down a notch. It's actually low cortisol, hypotension, and weakness.
It's okay. No one's perfect anyway.
We'll see about that. And finally, prolactin deficiency.
And that's failure of lactation postpartum.
Exactly. So the symptoms depend on which hormone is decreased.
And in panhypopituitarism, all of them are down.
Precisely.
What should we do to diagnose a patient when we're suspecting hypopituitarism?
We need to start with baseline pituitary hormone levels.
So we check everything.
Yep. Check cortisol, TSH, free T4, LH, FSH, prolactin, and GH. If you need to, you can follow up with stimulation tests like insulin-induced hypoglycemia for GH and ACTH. And don't forget, MRI of the pituitary to look for tumors, infarcts, or signs of infiltration to try and identify the underlying cause.
And I'm guessing this is one of those things that you don't want to miss. Because if there is cortisol deficiency and you leave it untreated, that could be really dangerous.
Definitely. Cortisol deficiency is life-threatening. So if you suspect hypopituitarism, you must start by replacing steroids.
All right, perfect. So when it comes to managing these patients, we need to replace their cortisol by steroids. And by logic, we also need to replace any other suppressed hormone, right?
Yes. Treating these patients is all about replacing any hormone they're missing. But keep in mind that there is actually an order to it. We always start with glucocorticoids like hydrocortisone because if you replace thyroid hormone first, you can trigger an adrenal crisis.
Oh, really? Why does that happen?
Basically, if a patient has both central adrenal insufficiency and secondary hypothyroidism because of their hypopituitarism, their hypothyroid state lowers their metabolic rate, and this makes them tolerate the adrenal insufficiency. If you treat their hypothyroidism first, their metabolic rate goes up too quickly and their adrenal gland can't keep up, so it sort of crashes.
All right, got it. So we must replace cortisol first using steroids. But then what?
After steroids, we treat other deficiencies. So you give thyroid hormone, and at the end, you can replace sex hormones or growth hormone if needed.
Thinking 2 steps ahead, is giving growth hormone really necessary if they're already adults?
Most of the time, they never require growth hormone replacement because there isn't really much benefit. And keep in mind that it's pretty expensive.
Are these hormone replacement therapies really that amazing, or are there any major problems that could arise from them?
The thing is, you need to be very careful and never give growth hormone to a patient with active cancer because growth hormone, from its name, makes everything grow, and that includes cancers. Also, you must not give testosterone replacement to patients with prostate cancer because it can make it worse.
So we need to monitor PSA level if we're giving a patient testosterone replacement therapy, right?
Yep.
Alright, so bottom line if you have a patient with multiple hormone deficiencies, you should always check the pituitary and replace any deficiencies, starting with cortisol replacement. Okay, before we get too comfy, let's hit you with a quick practice question. What do you think, Ghedaa?
Let's do it. We have a 35-year-old postpartum woman presenting with fatigue, amenorrhea, cold intolerance, and inability to breastfeed. She had significant blood loss during delivery. Labs show low TSH, low cortisol, low LH and FSH, and low prolactin. What is the most likely mechanism of her condition? The answer is infarction of the anterior pituitary, aka Sheehan syndrome. It's one of the causes of hypopituitarism, which is caused by inadequate perfusion of the enlarged anterior pituitary following postpartum hemorrhage. And always remember the keywords: inability to breastfeed and history of postpartum hemorrhage.
Let's push through and move on to our next case.
In our next case, we have a 42-year-old woman who presents with fatigue, weight loss, and episodes of nausea and vomiting. On examination, her blood pressure is low, especially when she stands up, and she looks pale and unwell. Lab tests show low morning cortisol and inappropriately low ACTH. Electrolytes are mostly normal. She has no history of steroid use. You do an ACTH stimulation test, and her cortisol levels fail to rise appropriately.
So we've got fatigue, weight loss, postural hypotension, and low cortisol that does not respond to ACTH. Honestly, it sounds like classic adrenal insufficiency to me.
Precisely. The lack of response to ACTH stimulation test points us towards adrenal insufficiency. And because ACTH is also low, we can tell this is secondary because the pituitary can't make ACTH, and it's not a problem in the adrenal gland itself.
Right, so it's not a primary adrenal insufficiency, aka it's not Addison's disease. The adrenals are fine, they're just not being told what to do.
Yep, and this is what we call a secondary or central adrenal insufficiency. And it's one of the possible presentations in hypopituitarism.
Since the adrenal gland itself is intact, let me guess, we do not see hyperpigmentation, right?
Exactly. Remember, we said that the hyperpigmentation happens because of ACTH production.
Yeah, so surprisingly, my Nemo memory actually managed.
Okay, Mariam. So, if we're not making ACTH here, we will not have hyperpigmentation. Also, other than the lack of hyperpigmentation, you also don't usually see hyperkalemia because the aldosterone levels are fine, unlike in primary adrenal insufficiency.
Oh, right, because aldosterone is still doing its thing thanks to the RAS system or the renin-angiotensin aldosterone system and not ACTH itself.
Exactly.
We talked about ACTH stimulation test. Can we dig deeper into that, please?
Okay. Generally, when you're diagnosing adrenal insufficiency, you start with an early morning cortisol level. If it's low, check ACTH. Then, if ACTH is also low, you're thinking central. Then, we do the ACTH stimulation test, where we give an ACTH injection and see what happens to cortisol levels.
And just to confirm, what's considered a normal response after giving ACTH?
Normally, when you measure cortisol 30 or 60 minutes after injecting ACTH, its levels should rise above 500 nanomole per liter. If it doesn't rise to that level, we can safely say it's adrenal insufficiency. You can also use the insulin tolerance test, where you give the patient insulin to put them in hypoglycemia and wait to see if cortisol rises. Normally, it should rise when you have hypoglycemia, but it wouldn't rise in cases of adrenal insufficiency. However, this test is way more complex and risky, and we don't do it very often.
Alright, so mainly we use ACTH stimulation test when diagnosing adrenal insufficiency. Got it. What about the treatment?
Since these patients are lacking cortisol, we need to give them steroid medication, like hydrocortisone. The timing of administration of these steroids should mimic the normal circadian rhythm of cortisol release. So, basically, they take the highest dose in the morning and then a slightly lower dose in the afternoon and nothing at bedtime. That's because you don't normally have much cortisol released at night.
And since cortisol normally spikes during stress or when our body is sick, I'm guessing we would need to up the steroid dose, no?
Yeah, you're right. In times of stress, illness, or trauma, the dose should be doubled temporarily to mimic normal conditions.
And no need for mineralocorticoids in patients with central adrenal insufficiency, right?
Right. That's the key distinction from primary adrenal insufficiency. Aldosterone is still intact in central, so we don't need to replace their mineralocorticoids.
These patients should also wear a medical alert bracelet, just in case paramedics needs a heads up during an emergency.
Yes, that's also very important.
All right, let's throw in a quick practice question before we jump into the next case.
Sure. A 42-year-old woman presents with fatigue, weight loss, and postural hypotension. Labs show low cortisol and low ACTH. What is the most appropriate next step in making your diagnosis? The answer is ACTH stimulation test, where the cortisol level will stay low after ACTH stimulation in case of adrenal insufficiency.
Okay, our next disorder is gonna be.
Wait, Mariam, I'm getting a call. Hold on.
Who is it? Who is it?
I think it's the thyroid. It's saying it's not getting enough stimulation from either the pituitary or the hypothalamus. That's weird.
Wait a second. Isn't that central hypothyroidism?
Ah, yes. The thyroid gland is not getting enough stimulation from either the pituitary or the hypothalamus, so instead of high TSH, like in primary hypothyroidism, here you'll see both TSH and free T4 being low.
Do you also treat it with levothyroxine like you would in primary hypothyroidism?
Yeah, you give levothyroxine just like in primary hypothyroidism, but you adjust the dose based on free T4, not TSH. TSH is not a reliable test to monitor while managing these patients because it will not go back to normal.
And super important, if the patient also has adrenal insufficiency along with their central hypothyroidism, we have to fix the cortisol situation with steroid therapy first before we fix their thyroid function. Otherwise, things can go downhill real fast.
Yes, and this is very important to avoid an adrenal or Addisonian crisis, just like we talked about.
All right, time to meet our next case. And spoiler alert, this one's feeling a little low energy, and you'll see how. Ghedaa, take the stage.
Thank you, Mariam. Up next, we analyze a case of a 38-year-old man who's been complaining of persistent fatigue, reduced exercise tolerance, and unexplained weight gain, mostly around his abdomen. He says he just feels out of sorts, kind of like he's aging faster than he should. On examination, you note central obesity and decreased muscle mass. Labs show low IGF-1, and a previous MRI had revealed a history of a non-functional pituitary macroadenoma, treated with surgery a few years ago.
All right, so low energy, central obesity, and low IGF-1. Sounds like growth hormone deficiency, especially given his pituitary history, no?
Yes, you're right. Growth hormone deficiency isn't just for kids with short stature. Adults can get it too, usually as part of a broader state of hypopituitarism, like after pituitary tumors, surgery, or radiation. Basically, any of the causes we talked about.
And it can be tricky to catch because the symptoms are kind of vague and overlap with a lot of other conditions.
Definitely. It's one of those conditions that can look like burnout, depression, or metabolic syndrome. So you should have it at the back of your mind when you see any of these similar presentations.
We said that growth hormone does all of its effects via IGF-1. So if there is a GH deficiency, that means that IGF-1 will also be low, no?
Exactly. And that's what we see in our patient here. This fall in IGF-1 levels is what leads to all the signs and symptoms.
What kind of signs and symptoms are we thinking of in adults with growth hormone deficiency?
The main ones are fatigue and low energy, central obesity, reduced muscle mass and strength, poor exercise tolerance, and some patients report feeling unwell, depressed, or just not themselves.
Okay, so all of these were for adults. Now, obviously, kids with growth hormone deficiency would have a different presentation, right?
Yeah. These kids would have growth failure and dwarfism.
That sounds pretty intense. So how do we actually confirm the diagnosis? IGF-1 is helpful, but is that enough?
See, the thing is, the first step is checking IGF-1 because remember, that's our indicator for GH levels. But sometimes IGF-1 can't help us with the diagnosis for sure. In that case, we need to do dynamic simulation tests like insulin tolerance test or glucagon stimulation test, or the growth hormone releasing hormone GHRH arginine test.
Okay, why so complicated? Can't we just use GH levels?
As we mentioned before, GH is released in pulses, so we can't rely on its levels.
Correct me if I'm wrong, but we said that treating GH deficiency in adults isn't really helpful, right? Especially because they obviously don't need to grow anymore.
Exactly. As we said previously, we wouldn't usually need to give these patients growth hormone if they're adults because they very rarely experience any benefit and they are expensive drugs. So if their GH deficiency is accompanied by other pituitary hormone deficiencies, we would treat the other hormones and see if the symptoms improve. If they don't, then we can try to give them GH and see what happens. In some cases, it can work, and if it does, it can improve their muscle mass, exercise capacity, bone density, and even quality of life.
And it's given as a subcutaneous injection, right?
Yes, that's another reason why they're not preferred if the patient doesn't benefit from it. During treatment, you should monitor IGF-1 levels and adjust the dose of GH if needed.
Just to recap, GH therapy is avoided in patients with active cancer because it can worsen the disease.
Exactly. If a patient takes growth hormone and they happen to have an active cancer, their cancer could definitely get worse.
All right, let's close this one out. Can you guess what time it is, Ghedaa?
Another practice question, I guess. Well, we have a case of a 38-year-old man presenting with central obesity, fatigue, and reduced muscle mass. He has a history of pituitary macroadenoma resection. His IGF-1 is low. What is the most appropriate next step to confirm your diagnosis? The answer is to perform a dynamic simulation test, such as insulin tolerance test. IGF-1 is helpful for screening, but GH deficiency must be confirmed with a stimulation test.
All right, enough of that. Can we move on to our next case, please?
Sure. We've got a case of a 28-year-old man who's been feeling constantly thirsty and says he's drinking nearly 6 liters of water a day. He's waking up multiple times at night to urinate and even had to pull over during a long drive because he couldn't hold it. He denies any history of diabetes and his blood sugar is normal. Labs show dilute urine with a low urine osmolality and elevated serum sodium.
So, in medical terms, we're saying polyuria and polydipsia, but the sugar is normal. So, is that diabetes insipidus?
Yes, that's most likely. So now, we're done with the anterior pituitary and moving on to the posterior pituitary.
But what really happens in diabetes insipidus then? Is it a deficiency in ADH?
That depends. If it's central DI, then it's a deficiency of ADH because the posterior pituitary isn't releasing it. But sometimes you may see nephrogenic DI, where you have all the ADH you need, but the kidney is not responding to it as it should.
All right, if you get a patient with such classic symptoms, how do you go about diagnosing it?
You need to start with labs. Like we saw in our patient here, a patient with the eye would lose all their water through urine. So they would have high serum osmolality, low urine osmolality, and hypernatremia. After these lab results, we need to do a water deprivation test. Basically, you stop the patient from drinking water and see what happens. If the urine remains dilute when they're deprived of water, that's DI.
I'm kind of confused, not gonna lie. How can you tell if it's central or nephrogenic DI?
You give desmopressin, which is basically ADH. If the urine becomes concentrated, so the problem gets fixed after giving desmopressin, then that's central DI. Because you technically just replace the hormone they're missing.
That's interesting. But what if the urine stays dilute even after the desmopressin?
Then, in that case, it's nephrogenic DI. So the kidneys aren't responding to ADH. Basically, if it's nephrogenic, nothing changes in the patient's urine after giving desmopressin. Because their problem isn't even a lack of ADH to begin with.
So, in short, the kidneys are totally fine, they're just not able to respond to ADH.
Yes, exactly.
Let's focus on central DI for now. What are some of its possible causes?
Central DI may be due to a pituitary surgery damaging the posterior pituitary, and this is probably the most common cause in the hospital setting. It can also be due to craniopharyngiomas, which we'll talk about later, or due to lymphocytic hypophysitis or pituitary apoplexy. Then, less commonly, DI could be from trauma or even idiopathic.
Alright, so how do you go about treating central DI?
Since they're lacking ADH, you give it to them. Our go-to drug here is desmopressin, or DDAVP. You can give it as a nasal spray or a sublingual tablet twice a day. You should also monitor fluid intake and electrolytes, especially sodium, to avoid overcorrection or any complications.
We already said that one of the causes is due to surgery. Can that be transient?
Yes, post-op DI is often temporary and resolves spontaneously, but some patients may need long-term therapy.
I hope your coats are still on. Let's take one last practice question.
Up next, we analyze the case of a 28-year-old man presenting with excessive thirst and urination. Labs show high serum osmolality, low urine osmolality, and elevated serum sodium. His urine osmolality increases significantly after desmopressin administration. What is the most likely underlying mechanism? The answer is deficient secretion of ADH from the posterior pituitary, the key mechanism in central diabetes insipidus.
All right, on to our next case.
We have a 10-year-old boy who's been experiencing progressive headaches, difficulty with school, and poor growth over the past year. His parents say he's also been drinking a lot of water and urinating frequently. On examination, he's below the growth curve, and visual field testing reveals bitemporal hemianopsia. An MRI of the brain shows a 3.5 centimeter supracellular cystic and solid mass with calcifications.
Delayed growth, visual field loss, and a big cystic mass on imaging. He has some sort of cellular mass causing symptoms of mass effect. Since he also has polydipsia and polyuria, this sounds a lot like a craniopharyngioma, huh?
Yes, we should definitely consider it in this case. Craniopharyngiomas are benign, slow-growing tumors.
And they're mostly seen in kids, right?
Yes, but they do have a bimodal age distribution, where they first peak in childhood between 5 and 15 years, and then again in older adults, around 65. But the pediatric presentation, like in our case, is more common.
Perfect. But from where exactly do these tumors come from?
Craniopharyngiomas originate from remnants of the Rathke's pouch, which is the same embryologic structure that gives rise to the anterior pituitary. You can think of it like some leftovers were left behind while we were building the anterior pituitary, and these leftovers ended up forming a tumor later in life.
I'm guessing the symptoms like headache and visual field disturbances are due to what we mentioned before, a mass effect.
Yes, exactly. So, because of where they sit, right in the supracellular region, near the optic chiasm, hypothalamus, and the pituitary gland, as they grow, they can compress those structures and lead to visual changes, endocrine dysfunction, and even diabetes insipidus, if the posterior pituitary or hypothalamus is involved.
So that's why our patient has both polydipsia and polyuria.
Precisely.
Okay, let's explore the pathology aspect a little deeper. What do we see under the microscope?
Craniopharyngiomas generally have two histologic subtypes, which are the adamantomatous type and the papillary type.
Wow, now that's a mouthful.
I know, right?
How would that mass look on imaging though?
These tumors are often described as having both solid and cystic components, with calcifications seen on MRI or CT.
Alright, and to recap the symptoms that they may present with,
they may have visual disturbances, especially bitemporal hemianopia from optic chiasm compression. They could also have growth failure or delayed puberty due to hypothalamic pituitary axis disruption because of the compression. They might experience polyuria and polydipsia from diabetes insipidus if the posterior pituitary or hypothalamus is compressed. And because of the mass effect, they might have symptoms of raised intracranial pressure like headaches, nausea, or behavioral changes.
whoa, and the kid in our case had almost all of those features, right?
Yep.
So how can we really treat it? This sounds like something that might need surgery, right?
Yes. The first line is surgical resection, but it's not always easy because of how close the tumor is to vital structures. That's why you might commonly see incomplete resection or recurrence.
Okay, and how can we really prevent that?
They sometimes use radiation therapy as adjuvant treatment with surgery or when the tumor can't fully be removed, to make sure they're eliminating recurrence as much as possible.
This is definitely going to cause some damage to some of the hormonal axes. We need to provide hormone replacement therapy for these patients.
Yes, especially if the pituitary is damaged during surgery. They may need lifelong hormone replacement for things like cortisol, thyroid hormone, sex steroids, or desmopressin, which is basically ADH, if they are experiencing diabetes insipidus.
Alright, so to sum up this case, craniopharyngiomas are mostly seen in children. They can present with headache, visual field defects, growth delay, and polyuria, polydipsia. And upon imaging, it shows supracellular cystic and solid mass with calcifications.
Yes, and it's a pretty high yield case because symptoms can mimic other pituitary or hypothalamic disorders.
Now, let's go for another practice question.
A 12-year-old girl presents with growth delay, bitemporal hemianopsia, and frequent urination. The MRI shows a 3.5 centimeters suprasellar mass with both cystic and solid components. What are the two histologic subtypes seen in this condition? The answer is number 1, the adamantinomatous type, and number 2, the papillary type.
Can you believe it? We have arrived at our final case for this episode.
Finally, we meet our last patient, a 17-year-old boy who comes in with concerns about not hitting puberty. He has no facial hair, no voice deepening, and his testicles are still very small. His mom says he's also never had a good sense of smell, even as a kid. On physical exam, his arm span is noticeably larger than his height, and he has gynecomastia. Hormonal labs show low LH and FSH and low testosterone.
Okay, so he has signs of hypogonadism and he can't smell. It's giving Kallmann syndrome?
Exactly. Kallmann syndrome is a form of congenital hypogonadotropic hypogonadism. So basically, the problem is at the level of the hypothalamus or pituitary, not the testes.
And the anosmia is a pretty key feature here, right?
Yep. If you see hypogonadotropic hypogonadism plus anosmia, you should directly think of Kallmann syndrome.
So what's actually going on in here?
During development, the GnRH producing neurons are supposed to migrate from the olfactory placode to the hypothalamus. In Kallmann syndrome, the migration doesn't happen, so the hypothalamus never gets the neurons that make GnRH like it normally should.
Oh, so since there's no GnRH, the pituitary never gets the signal to produce LH nor FSH.
Exactly. So it's kind of like a tertiary hypogonadism, because the problem is in the hypothalamus.
What about the anosmia in this case? It seems kind of random.
Remember how we said that the GnRH producing neurons are supposed to migrate from the olfactory placode to the hypothalamus? So, we do have a problem in the olfactory bulbs. Basically, they're hypoplastic or absent. And that's why the sense of smell is affected.
Oh, that makes sense. And this is a genetic condition, right? What's the inheritance pattern in this one?
The most common form is an X-linked recessive mutation in the Cal1 gene, and that's why it's more common in males.
But maybe it's just underdiagnosed in females, no?
That's possible. The clinical features can be more subtle in girls, so it's often missed or diagnosed later.
Alright, so we said that they have anosmia or reduced sense of smell. And we also said that they have features of hypogonadism. What does that look like?
Hypogonadism can manifest as delayed puberty or primary amenorrhea. Boys could also have a eunuchoid body habitus, which means their body looks more feminine and they have long limbs. So basically, their arm span is longer than their height. They also have small testicles, a micropenis, scant pubic hair or facial hair, and gynecomastia. In some cases, these patients may also have associated anomalies like cleft lip, renal agenesis, or bimanual synkinesis, which means that if they move one hand, their other hand mirrors it.
Alright, what's the best treatment approach for these patients?
Depends on the goal. For puberty induction, boys get testosterone injections and girls get estrogen. For fertility, later on in life, you can give them HCG and FSH. Sometimes they may be given pulsatile GnRH therapy, which mimics natural GnRH signal from the hypothalamus to trigger puberty.
Wait, so in this condition, the GnRH therapy actually works?
Yes, because the pituitary is structurally normal. It's just not getting the signal. So if you give pulsatile GnRH, it can stimulate the release of LH and FSH just like it would naturally.
Alright, so in Kallmann syndrome, you would typically see a tall teenage boy with delayed puberty, small testes, gynecomastia, and anosmia. Hormones which show low LH, FSH, and testosterone. Alright, let's test the patience of our listeners and ask one more practice question.
We have a 17-year-old male presenting with delayed puberty, small testes with lack of body hair, and anosmia. Hormonal labs show low testosterone, low LH, and low FSH. What best explains the pathogenesis of this condition? The answer is failure of GnRH neuron migration to the hypothalamus.
Okay, that was a lot. Let's quickly recap everything we talked about to make sure we're good to go. First, we talked about hyperfunctioning pituitary adenomas, starting with Prolactinoma, which is the most common functioning pituitary adenoma. These tumors cause excess prolactin, leading to amenorrhea, galactorrhea, infertility, and low libido. Diagnosis starts with checking serum prolactin, and if it's above 200, you should think of macroprolactinoma. MRI confirms it. Treatment is medication, as first line mostly with cabergoline, with surgery reserved for resistant cases. Prolactinoma is the only one of the tumors that we discussed today where we start with medications and not surgery.
And then we jumped into GH secreting adenomas. In kids, that means gigantism, and in adults, it means acromegaly. With changes in facial features, enlarged hands and feet, and metabolic complications like diabetes and hypertension. Screening starts with IGF-1 and then diagnosis is confirmed by failure of GH suppression after glucose. Surgery is first line for GH adenomas, and medical options include somatostatin analogs like octreotide and GH receptor blockers like bevacizumab.
Next, we talked about Cushing's disease, caused by corticotroph microadenoma producing excess ACTH. Patients present with a moon face, central obesity, purple striae, proximal muscle weakness, and new onset diabetes. Workup starts with screening tests, including dexamethasone suppression test, midnight salivary cortisol, and 24-hour urinary free cortisol. Then, we measure ACTH levels to localize and perform inferior petrosal sinus sampling, or IPSS, to confirm. Cushing's disease is treated by transsphenoidal surgery, and always watch out for Nelson's syndrome if you end up removing the adrenals.
After that, we talked briefly about TSH secreting adenoma, the rarest of the bunch. It looks like hyperthyroidism, but TSH is usually elevated, which wouldn't happen if it were Graves'. The giveaway for diagnosis is a pituitary mass on MRI and often an elevated alpha subunit. Treatment is by surgery, but these tumors may also respond to somatostatin analogs.
Next, we move on to hypofunctioning pituitary lesions, and we talked about the different causes of hypopituitarism, where the pituitary fails to produce one or more hormones and at least 75% of the gland is destroyed. The order of hormone loss varies, but management always starts with glucocorticoid replacement, followed by thyroid and others.
In hypopituitarism, we started with the non-functioning pituitary macroadenomas. These are hormone-silent tumors that grow quietly until they're big enough to cause mass effect. Symptoms include headaches, Bitemporal hemianopsia, and sometimes hypopituitarism if they compress the normal pituitary tissue. Since they're macroadenomas, MRI is key. Treatment is surgical resection, with hormone replacement if needed. Other causes of hypopituitarism include surgery, radiation, and in postpartum women, Sheehan syndrome from ischemic necrosis of the pituitary gland.
Then we covered central adrenal insufficiency, which is caused by low ACTH from the pituitary. These patients present with fatigue, weight loss, and postural hypotension, but without the hyperpigmentation or hyperkalemia you would see in primary adrenal insufficiency. Diagnosis is through the ACTH simulation test, and treatment is hydrocortisone, with a double dose during periods of stress.
After that, we talked about central hypothyroidism, where both TSH and T4 are low. Patients feel sluggish, cold, and constipated. And the big rule is, if they also have adrenal insufficiency, treat cortisol first, before starting levothyroxine, to avoid adrenal crisis.
Then came the growth hormone deficiency, and it's not just for kids. Adults with GH deficiency can feel tired, accumulate central fat, and lose muscle mass. Low IGF-1 is the first clue, but you need dynamic testing to confirm. Treatment is with daily GH injections, reserved for patients who do not improve upon correction of other hormone levels.
We also covered central diabetes insipidus, which is all about ADH deficiency. These patients have polyuria, polydipsia, and dilute urine. Is confirmed with a water deprivation test and treated with desmopressin. Common causes include pituitary surgery, craniopharyngiomas, and lymphocytic hypophysitis.
Then we talked about craniopharyngioma, a benign but locally aggressive tumor that more commonly affects children. It arises from rat case pouch remnants and causes symptoms like growth failure, visual field loss, and diabetes insipidus. Imaging shows a mass with both cystic and solid components with calcifications, and histology could show one of the two subtypes, with the adamantomatous type or the papillary type. Treatment involves surgical resection, often followed by radiation, and most patients end up needing long-term hormone replacement.
And finally, we wrapped up with Kallmann syndrome, a congenital condition where GnRH neurons fail to migrate to the hypothalamus, leading to hypogonadotropic hypogonadism and anosmia. Think no puberty and no sense of smell. It's often due to an X-linked recessive mutation in the Kallmann gene, and treatment depends on the goal, either testosterone or estrogen to induce puberty, or HCG and FSH for fertility.
Okay, cute. That was a packed one. But if you're still with us, congrats! You've officially explored the entire pituitary, from hormone-secreting adenomas like prolactinomas and Cushing's disease to quiet but destructive conditions like non-functioning macroadenomas or craniopharyngiomas. Thank you so much, Ghedaa, for joining us today, and I hope I didn't tweak a bunch of your neurons.
Thank you for asking, Mariam. My neurons are tweaked, but I had a lot of fun. So thank you for having me.
Of course, anytime. And thank you to our listeners. That's all for today's episode. Don't forget to follow us so you don't miss future episodes. And you can now leave a review in the description below to help us improve with every episode. We'll catch you next time on PodBites.
Meow, meow, meow. Meow, meow, meow.
Because that can eliminate 2 out of the 4 main differentials of elevated cholesterol.
يا شباب والله مو طبيعي. عم بقرا كلام.
If I remember correctly, it has 2 main parts, the anterior and the posterior pituitary.
غيداء ولا بس مريم؟ اوكي طيب ابلش ما حكيت طيب سوري